Adi has the coolest screen.
We are live now, Doctor.
Thanks so much, Nirmal. Thank you.
Okay, thank you, Manjula. Yeah. Good evening, friends. On behalf of Tamil Nadu Ophthalmic Association and myself and all the office bearers of TNOA, I extend a warm welcome to a special webinar today on toxic anti-segment syndrome and sterilization technique. No, these we have decided to have this webinar in a different mode when rather than having a series of talk things. We thought we can have a series of questions, which is commonly all of us will have in our day-to-day when you face this type of problem. In that, this task is not uncommon, but of course, it's always better to be familiar with this type of communication, especially because all of us are doing cataract in our day-to-day practice, which is better for all of us. And also, this type of communication, of course, we don't want to have in our practice, and also the endophthalmitis. But there are certain things, how to identify this task. That's one aspect. And second is how to differentiate from endophthalmitis. Third important one is how to prevent it, because this type of catastrophe is always better to be on the other side. We have to take as much as possible precautionary steps to prevent this type of complication, because once it happens, then it's very, very difficult to regain the normal vision, because all of us, everybody is doing wonderful surgery nowadays, whether it's TACO or SACS. We may think that we have done a wonderful job in the table, nice Rexis and nice TACO with good civil standard IOL, no eye is so quiet, patient is comfortable, but next day we don't know what will happen. That's how it's history most of the time. It may 99% may go very well, but at 1% also minor things like severe corneal edema or SK or something like that. But now this type of thing, the toxic anti-segment syndrome also is very, very not common, you cannot say, but it occurs in outbreaks. We have so much of cases in the North India. Fortunately, in our state, we didn't have much of cases. So we thought we have to sensitize our own members and other people how to suppose they have this type of problem, how to handle it, what are the precautionary steps and other treatment modalities and other legal aspects we have to take. That's why we have organized a seminar, and we have wonderful panelists for this seminar. I'm really very happy to see a galaxy of panelists, including Dr. Armuli Varman, Dr. Nirmal, Ramesh Dorajan, and Sivakumar. And some people may be joining, Kalpana. And of course, Mohan Rajan, he told that he will try to join, and R.D. Ravindran, Haripriya, and Sriram Gopal, and Sudarshan, Sirish Kumar, of course, he has got wide experience, and Pramod from Hemanandini. All the people are very well, they are in their respective field. In addition, we have one more, it's a not clinical, but he is one of the important persons, Mr. Krishna Kumar. He is from our lab. He has got wide experience in what's the basic of this task, why it happens, and what are the endotoxins. He has done a lot of work. So he'll be sharing his experience also. This background of this webinar. I once again welcome all of you for this webinar. And also, I have to thank my dear Chandrasekhar, because this type of problem comes, so immediately we think of 2 or 3 people like Chandra Kumar, Nirmal, and Adiyar, and some people like that. So I told him immediately he arranged this webinar in a different format. So with these words, I asked Nirmal to give a few words, and then Arul. Then I'll hand over the mic to Chandrasekhar. Yes. Nirmal is the incoming president of the Tamil Nadu Ophthalmic Association.
Thank you, President. And thank you for organizing this important and burning topic of TASS. And thank you, Chandrasekhar, for inviting as well as organizing this webinar. I'm sure this will be a very useful and timely one for all our members.
Yes.
And so just to give a background of this TASS, I think the spark started from Chennai with Dr. Sudarshan reporting few cases of TASS and the way he handled it. And followed by there was a lot of postings in the WhatsApp group. So every reaction was named as TASS and linked to certain consumables we used in the theater. So till then there was no reports, but once one report came in one of the groups, the wildfire started, and from every group, everybody started reporting TASS. So it was reported to one company and one product commonly. So then it was spread over many consumables like the viscoelastic substances, the IOLs, particularly hydrophilic lenses, and the BSS. So these are common used intracameral agents or medications. So the report was from wide area across India, as well as from many consumables. And of course, there was one commonality, or most of the thing was the hydrophilic lenses. Then experts thought it is because of the fluid or the surface or the sterilization. So we wanted to have the root cause. The company also started investigating some of the batches, and finally the AOS stepped in. The task force of AOS received a few reports from across the country. They were able to identify about 22 affected batches, most of them belonging to one company and one set of hydrophilic lenses. The company has taken the report and also sent it for analysis, both aerobic, anaerobic, as well as the toxicity for the toxic components in the lens surface as well as the component. So as of now, we don't have any concrete evidence. Unfortunately, many of our members didn't report this to the only agency available for this in India, that is the Pharmacovigilance Commission. For materials, it's called as Materiovigilance Commission. So this have not received any inputs so far. So now there are AOS members have joined and given few incident report in pharmacovigilance also. So hopefully when there are many such reports, they'll take up the case and try to investigate and also get all the inputs from the various companies. So this is the present status. Thankfully, most of the incidents were controlled by our members, treated well, and not much of negative incidents or vision loss happened to the patients. And thankfully, since it was sporadic and spread all over the geographic area of the country, it didn't reach the media in a big way, but it did give considerable headache to our doctors, professionals, and the surgical team, and also created a lot of anxiety among the surgeons and the surgical teams on what lenses to use, what to avoid, what products to keep an eye on, all these things. From the accreditation or from the expert point of view, it also had a focus on the sterilization methodology as well as the various aspect of surgical setups. So that actually there's a renewed interest on this now, what type of sterilization to use, what autoclave to use, and how to focus on getting the right vendor, right consumable, right product, and how to use. And also focus on, since TASS is a sterile toxic entity, so whether we are overusing sterilization, overusing chemical sterilization. So a lot of focus on these areas happened. There were many webinars across the country, and now we are doing this webinar for the benefit of our members. Maybe I'll highlight 5 points to conclude this just orientation. So every hospital is different. So we can't copy what is happening. One hospital policy cannot be copied in a small setup. What is good for a large setup may not work well for a small setup. So we have to find the optimal sterilization method as well as optimal infection control method. So somewhere we have to hit the sweet spot between minimal to full hospital infection control. So the clinical leadership has to be sensitized and of course trained. So many of us are not updated on this. So this is one step from the TNOA to update our members on this. The second thing is the geographical consideration. So the infection control policy have to be customized to the needs of various places. So it also specific, location specific, climate specific, particularly this incidence. There was one study that these incidents happen more during this rainy season and the cold season. So which means there is some element of climatic changes also involved in this. So we have to have this in mind. And we also need to get the basics right. So we need to have a good structure to give quality result to our patient and also be safe in our practice. So we have to have all the regulatory requirements in place. And now the zoning is important part of Clinical Establishment Act. So many of our establishments don't have this. So we need to focus on that. And we also need to have a comprehensive approach on using the right chemical with the right concentration, the right methodology. And of course, the last one is monitoring our staff and training our staff. So if we can focus our discussion on these important areas, this would be a real eye opener and learning point for all our members. Thank you so much, Chandru. Thanks for President.
Thank you, sir. Thank you, Dr. Nirmal. Now I request our Vice President, Dr. Arulmozhi Varman, to give his opening remarks. Sir, over to you, sir.
At the outset, Chandrasekhar, wonderful program that you put together. Let us discuss in detail about TASS, because this is something that's a bugbear. First, we need to know how to identify TASS and then treat it appropriately. Then we need to find out what are the causes of TASS and how to avoid it in our practice. That's a whole lot of other work to be done. Most often it is to do with our own sterilization procedures, cleaning procedures, residues left over from enzymes or any other detergent that we use. So many things are there, including the quality of water that we use in our autoclave. That's extremely important. That is one where most of us will fail. It's not just using the appropriate autoclave or any other method. It's the quality of the water in that. So let's not, I won't like to waste too much time. It's a fabulous program that's laid out here. Let's get on to the program with less words. Thank you.
Thank you so much, sir. Thank you so much, sir. We have a friend, Dr. Sudarshan here. He'd like to give a brief on exactly what happened and being, the first person to report a cluster of TASS. Over to you, sir. So you're muted. You're muted.
Good evening, everyone. First, I would like to thank Dr. Chandrasekhar and Dr. Nirmal Reddy to give this opportunity. And before starting my experience, I would like to say a disclaimer here that I have nothing against the company that is in question now. And we have been using their products for the past 5 years. And I'm still using their hydrophobic lenses, and only the hydrophilic lenses I have stopped using. And this was an eye opener. And we went through a painful process, but thank God we identified correctly. What happened was in November, we started getting few cases of TASS. These cases were like fibrinous reaction in the eye on the first post-operative day. And initially, we thought maybe we are not washing away the visco and the retained visco is causing this problem. So we thought of washing the eye thoroughly before closing the surgery. But this did not help us. Next day, there was a TASS. So we wanted to change the water that we are using for the autoclave. We actually started buying new cans from outside, RO water, and started using it. But at the same time, we used to send that for culture also. We identified many of these were growing coliform bacteria. And finally, we settled with Bisleri. Bisleri was totally sterile. And so we were started using Bisleri cans. But yet the TASS cases did not stop. And then we thought we will stop using moxifloxacin. So moxifloxacin we stopped, but yet there were cases of TASS. So by December, actually, there were quite a few cases that had already accumulated. Exactly on December 12th, I sat down with all the case sheets. Actually, there were a few cases in November also, but I took out only those cases that happened in December. So December 12th, we had, by December 12th, we had 6 operating theaters in 4 different doctors had operated. We had about 54 cases. And in that, we had used about 26 hydrophilic lenses. And in this 26 hydrophilic lenses, 12 of them had TASS. And this TASS ranging from mild flare and cells to hypopyon. And some had fibrinous exudate blocking the pupil too. But thank God, all these cases were treated completely without any sequelae. All of them did get their vision back. Everything got settled. Some even needed systemic steroids, apart from the topical medications. But finally, when I sat down on that day, when I was searching for the common factor in all these cases, in all these 12 cases, there was only one thing that was crying to be picked up. That was RYCF lenses. This was the only common factor, and everything else was validated. That means it was good. So RYCF, I was damn sure about RYCF lenses causing this. So very next day, on 13th December, I reported this to Sri Ram. And then, yeah, as you know, the things started unfolding throughout the country. So what am I doing after this incident is lenses which are not preloaded, I'm washing them thoroughly before inserting into the eye. This is the only thing that I have learned in this episode. Thank you so much, sir.
Thank you so much, Dr. Sudarshan, for giving a short review on what you have done and overview. And once again, we thank Dr. Ramakrishnan for organizing this and bringing in this concept. Before we go to the discussion on some of the important points, I'd like to narrate my own experience, which is worth talking in this forum. About 12 years back, I was going to a secondary center in a town to operate phaco. So on a particular day, we had operated 25 cases. On day 1, I go to see the post-operative. 3 doctors were operating. On the day 1, we had about 15 cases which had corneal edema. Anterior chamber reactions were with fibrinous membrane, some with exudate, some was very minimal iridocyclitis. I went along, then I called my retinal surgeon, who is a friend, and we both saw the case, and there was no posterior segment reaction at all. But the corneal edema was diffuse and limbus to limbus, as textbook says. That was the first time probably I am diagnosing a case of cluster TASS. So we decided it is TASS. We gave subconjunctival mitricane and decaderon and hourly steroids and hourly antibiotics, and the patients were seen in the evening. Out of the 15 cases, almost 7-8 cases become totally all right. Next day morning, except 2 cases, everything else was clear, and the other 2 cases became all right within 48 hours. So what we did, only thing was our fear whether to go for intravitreal, whether to shift to a tertiary center or not. But we stopped the OT. We canceled all the cases on that day. And of course, only thing which we did was we changed the ringer lactate solution, which we were using at that point of time. That was a new batch we had taken recently. Subsequently, touch wood, there was no reactions at all. After 3 months, a similar episode occurred. We had the same kind of reaction, little more corneal edema. So again, the same retinal surgeon was with me. then we assume could also be a TASS and put on the same type of medicine. Evening, relatively only 3 or 4 cases were slightly becoming good, but others were having the inflammation. Next day morning, all 12 cases become full-blown endophthalmitis. They turned out to be pseudomonas endophthalmitis, and that is one thing which gave us a lot of lesson. So at this point in time, we are all there. We all know there is something TASS is occurring around. But I can tell you, there are at least three clusters that are happening in the country, which are infective endophthalmitis. So we need to also keep it in mind that this can also be there. But the line of difference between a TASS and infective endophthalmitis is very distinct. We have big experts like Dr. Pramod Bende and very many expertise here. So this discussion will be towards what we should do, how we diagnose and how we go forward, and when to really get the expertise. So we'll go on with the question answer session. First is I'd like to ask the forum how to really diagnose whether it's a case of TASS, whether it can be isolated or always a cluster. Anybody can, yeah, yes, Dr. Sirish, sir. You have to unmute, sir. You have to unmute. Yes, sir. Please go ahead.
My current experience is about 3 cases now. And one case was the second of a set of 3. And only similarity was, by then I had heard about RYCF lens, and there was RYCF lens in that particular eye. Now, the power was, I think, 21. And I do not know if batches alone, because manufacturers do fabricate or manufacture the lenses by batches. And it is possible that they must be manufacturing one particular power in one particular batch. It is possible that all the particular dioptric power of one particular batch could have this kind of problem. But in any case, this I did not get to see the case the second day, that is the first post-operative day. And someone in my department looked at the case, and as per the protocol, we started whatever was the initial treatment for endophthalmitis. It was later that day, that is by evening, because it was an endophthalmitis or suspected endophthalmitis, that I went and saw, and naturally a diffuse corneal edema, which did not correspond to usual my surgical trauma, if at all there was. Now, that was what made me think that, yes, this could be some toxic reaction. And I had the advantage of having heard this particular episode of TASS that is happening across the country. So therefore, I shifted the treatment to steroids from a pure antibiotic every second hour. Tobramycin and moxifloxacin regimen was shifted to steroid. And in about, say, 4 or 5 days, it got resolved. 5 days, I had to see the patient twice, asking her to come. And in each time, there was some improvement. And 5th or 6th day, then I was not in doubt, and I let her go. The second, this is about one case. The other 2 cases are still under treatment. And in the first 4 patients, that is 4 days, it has still not resolved. And nearly the status is almost stationary right now. But this does not pertain to this particular brand of lens, and it is another brand of lens, completely a different company. So this is something that I wish to bring to the notice of the people in general.
Thank you, sir. Thank you, sir. So can I have somebody telling exactly this is clear-cut case of TASS or infective, or at least maximum, when do we suspect a TASS? Yes, ma'am.
Usually when patients present with TASS, it can present between 24 hours to 48 hours, and they usually present with pain, and eye is fairly quiet, but there will be severe corneal edema from limbus to limbus. Antechamber reaction will be there. There might be fibrin membrane. The pupil might be dilated. There might be a hypopyon, and the intraocular pressure will be raised. So these are usually the, the signs which can say that it is a TASS.
This kind of patient, would you advise admission and a follow-up for at least 2-3 times? Or would you ask the patient to come back again, madam?
Based on the severity, if you think you can manage them, normally you give them steroids, but then unless you're very sure what it is, you should always keep endophthalmitis also in your mind. So if it is, if you think it is responding, maybe a day or two, you can call them as an outpatient and see them. And if needed, you can admit them if the disease progresses or if it needs intervention. But then very important to review them, regularly as often as required so that you don't miss out anything.
Thank you, madam.
So
Dr.
you're thinking
Sriram,
about
yes,
TASS.
Dr. Sriram.
Yeah, I just wanted to reiterate what Dr. Kalpana Madam said and add a couple of points. See, the name is self-explanatory. It's a toxic reaction. And the turnaround time for anything left in the anti-A chamber is hardly less than 6 hours, actually. So anything, let us say you operate today evening and open the eye tomorrow morning. If the eye was fine, then anything coming after that is very unlikely to be TASS, because by the time whatever you left behind in the anterior chamber will go, except obviously the IOL. So except say the intraocular lens, nothing else can cause TASS after the first day. That is one thing. Second thing is it is a toxic reaction, and depending on what causes it is what causes the type of reaction. Like what Dr. Sudarshan reported, one clue might have been it was more an inflammatory reaction rather than all the other findings which Dr. Kalpana said, like corneal edema and raised IOP and things like that. Usually things which you leave behind in the anterior chamber affect the endothelium more and also affect the trabecular meshwork, causing an increased IOP and corneal edema, or both. Whereas something which is not in the anterior chamber, like say a viscoelastic left in the bag or an intraocular lens, will cause more of an inflammatory reaction. But please correct me if I'm wrong, but invariably in TASS, it is very, very unlikely, at least in the initial stages, to have posterior segment involvement. So the first thing you see when there's a inordinate corneal edema or out of proportional corneal edema or severe reaction is, first thing is to assess the posterior segment. Either clinically or ultrasonically, best is to do both. So first thing to do is...
Yeah. Actually, also...
Go ahead.
Sriram, are you done?
No, yes, ma'am.
I also wanted to add an experience. This happened years ago that, one day we had operated, I had done 20 cases and then 12 of my cases had severe inflammation, a typical TASS-like feature. And then we retrospectively did analysis and we found out that, with the cassettes we use, reusable cassettes. So that had the, the cortical matter not cleaned properly. So sometimes it's reusable cassettes also we have to be, now we do the air blow, we dry them completely. But I'm saying that also can be, like we all know that retained cortical material in the tubing, in the reusable cassettes also can be one thing we have to be cautious. Just wanted to add it.
Sure. Yes, sir. Dr. Arul.
We'll have to keep in mind few things. Using RO water for autoclaving is not going to make us very safe. RO water can be sterile, but it need not be endotoxin free. So that's a major issue that can cause TASS. And even if you're using a air gun blower to clean all your instruments, hollow instruments, that particular air gun should have a HEPA filter built into it. It should have a proper filtration mechanism. Otherwise, you're blowing in some dirt into the tubings. These are two things that we need to keep in mind. We look at TASS. Please also do an anterior segment OCT. Often we can mistake TASS. Diagnosis can be made when you have a DMD, a small DMD somewhere in the middle of the cornea, not necessarily at the incision. Somebody during the chopping, you just touch the endothelium or made a small tear, and that will start allowing fluid to leak in. Look at that also. This will give us further information as to what they're actually dealing with TASS. I'll leave a question to the people on the forum now. How many of you would feel happy about using intracameral steroids when you have a typical TASS which is not settling down in 24 to 48 hours?
I think I will not consider initially.
And
also we'll have another question added to this, and how many of you would prefer to a YAG fibrinolysis immediately? So I think that also can be discussed as a point.
No, suppose the fibrin is occluding the pupil, no, and also Most of the time I used to do. In that case, the resolution will be very fast.
But that is
So can
after
I add a
the
point, sir?
after the
Can I add a point?
Yeah.
So usually when there is, what I practice is when there is fibrin occluding the pupil and I cannot see fundus, the first thing I do is I do a B scan. If I'm absolutely convinced the vitreous is clear, then I start the patient on very frequent steroids. I keep the patient in the hospital, maybe not overnight, but at least during the course of the OPD, at least for 3 to 4 hours, very frequent steroids and mydriatics. The other option is to use midriacane, which I don't. But usually this sort of, if it is a TASS, it sort of breaks the fibrin, makes the pupil dilate, and then lets me look at the fundus and make sure the vitreous is actually clear clinically. Because ultrasound has its own limitations, you cannot trust it. What is optically clear in ultrasound can be hazy on a clinical examination, and the vice versa is also possible. But I would want to know both before I decide the vitreous is not involved. PB sir, I want your comments on this.
Dr.
I
Pramod,
was
sir.
about to come that only because, see, most of the time we cannot see with the fibrin everything. Yes, by definition, we talk about very nice to say, ideally, TASS does not involve posterior segment, but you should be able to visualize posterior segment. That's the difficulty with the corneal edema, fibrin in the pupillary area, sometime added hypopia, and you can't see posterior segment at all. Yes, ultrasound definitely, at least, serial ultrasound, we have to add. But yes, initial stages, it's extremely difficult to differentiate between two. And when you are not sure about what you are dealing with, is better or on an endophthalmitis side, start on a topical antibiotic. As a dictum, any hypopion, irrespective of whether you think about TASS or not, our institutional policies, we tap it and send to microbiology at least. And intense steroid, obviously you are starting, even if you're sure more or less I am dealing with TASS, but what happens sometime by chance we are dealing with infection, the sample is already gone. If something comes out, then treatment won't get delayed. Topical steroid, topical steroid and antibiotic definitely would start, and depending on you get at least smear report, it will be coming within half an hour, 45 minutes. Most of us are having a lab within the campus. So that again helps you to add on here. But if you are not sure about what you are dealing with, I think are on endophthalmitis side, not on a TASS. But I think other features, everybody has very well discussed. I think I don't have to add anything beyond that.
Thank you, sir. Thank you, sir. Dr. Sriram, Shivkumar, 1 minute. Just to the first point you said, 24 to 48 hours, there are published reports proving that there are late TASS, especially in case of IOL-related late TASS is there.
That's exactly
Apart
what
from
I
that,
said.
majority of them are within 24 to 48 hours.
100%, because IOL is the only thing which stays inside the eye after the first 6 hours.
Yes.
Everything else goes away.
Correct. Just for the for the listener. Yes, Dr. Shivkumar, sir.
Yes, thanks, sir. I just wanted to add that all points have been said, what TASS looks like, endophthalmitis looks like, and the anti-segment findings can always be very confusing. At first look, probably we can never decide that it's TASS or endophthalmitis. The only probable thing is, like Dr. Gopal said, involvement of the posterior segment, and a drop in vision and a fundus obscuration or vitreous involvement on B scan will settle the issue. But what we have to keep in mind is that in case it's an endophthalmitis, then the infective agent has got to be very virulent, and usually the gram-negative ones, which means that the deterioration is likely to be rapid within the first 12 to 24 hours if we are not giving the appropriate treatment, or maybe even if we do give it. So I think that sequential observation and see what it responds to is probably what will settle the issue, rather than just a first look at it.
No, totally agree with you. Limbus to limbus edema sometime, and when early stage typically can be bacillus cereus when you're dealing with. So that obviously you have to keep in mind. Pseudomonas, yes, very quickly, very rapidly they progress. But yes, typically bacillus cereus, when you see initially they are just present with the limbus to limbus edema.
One more point, sir, about the B scan. In early stages, especially day 1, we may not get any finding at all. I have had the bad experience of doing B scan on 65 cases of postoperative endo. We increase the gain on the scan. We can find vitreous cells and vitreous opacities also, which will help us to identify whether it is in the anterior face alone or inside the vitreous also. So that is one point which I learned. Sir, Dr. Pramod, sir, any take on it, sir?
No, that's what I think Shriram has elaborated on it already, because this is nothing like what you can see actually visualize. But ultrasound gives some clue because of variable reflectivity, because of interfaces, and that's the thing. But if a diffuse haze, if you there, is there on ultrasound, you may not be able to pick up.
Yes, sir. Thank you,
Sometimes
sir.
the
Exactly,
presence of
narrated
echoes
already.
can be more confusing.
Exactly.
Vitreous can actually not be involved. You'll find few echoes. You won't know whether it is significant or not. That is a more
Agree.
confounding factor.
Yeah.
Because
It'll be
if
low
it
to
is
mid
infective,
echoes.
because if it is infective and limited to the anterior segment, you wanted to leave it like that. You don't want to go and stick a needle into the vitreous and push this behind. So in that
Exactly.
situation, comparing the echoes in that eye with a normal fellow eye where you're able to visualize the vitreous, if the echoes is comparable, you can take an indirect inference that this
Yes.
person's vitreous is this echogenic. Though it is not foolproof, it's an indirect inference.
Agree.
I just have one question for all the panelists. If somebody sees a TASS, you're sure it is TASS, leave alone diagnosing TASS, we're pretty sure it is TASS within the first 6 to 12 hours. How many would be for doing anterior chamber wash? One so far. Okay. Maybe
I
two.
think I will not do initially.
No, ma'am. Initially only I'm saying. Within the first 6 hours or so.
No.
I would prefer not
Clinically,
to
I
intervene,
don't
in
think
fact,
there is a
because you
role.
add on your surgical intervention and inflammation may be worsened further. I would prefer, and we know that most of them, they respond very well to steroids. I think just have an intense steroid, be patient, but have a close watch.
Thank you, sir.
But one advice I would like to give, if there is a cluster of TASS, better to keep them admitted. But there is a risk there. All of them get together and go against the hospital, which I have seen. They get together, they discuss, and then the whole scenario will change. But it is ideal to see at least 2 or 3 times on day 1 to see that even evening, late evening, you can start your treatment for the infective endophthalmitis. Okay, in a small hospital with 1 or 2 doctors, they see a TASS. One case probably they will manage. If they see a cluster, would you advise them to be referred to a tertiary center or call an expertise there? Or what would be the advice for a smaller center when they see a cluster of TASS? It's open to the forum.
Even smaller centers can have big doctors, sir. So
Big
therefore,
doctors. Yes, sir.
yeah. So therefore, the question is whether they can diagnose or not. And if they can diagnose, then treatment is plain and simple. And if
Sir, I will give
they
you
are
example.
confident of going ahead with the treatment, then there is no bar on retaining the
Same thing
patient.
we did, sir, for this cluster. Second time I told no, Pseudomonas, it was cornea. So there was no way we could do any vitrectomy, but intravitreals were given, B-scan was done, daily follow-up was done. And the case was subsequently referred to a tertiary center. When it blew up, it came to it came to public, all the TV, everything. One point that the investigating team asked, why didn't you refer to a higher center after you saw? This is something we know we can manage, but if it had been, the situations will vary. So that is why I asked that question, sir. Anybody
sir,
else
I
want?
think,
Can I add?
sorry, I think it's nothing like higher center or a lower center or, see, as long as you have facilities,
Yes.
as long as you are confident enough what you are doing, and as long as we know overall as any post-operative inflammation, I would say, whether it's TASS or infection or sterile endophthalmitis, and all of us know general protocol and systematic way it is being handled, and you know how to do it. I think there is no question of somebody, nobody issue of somebody questioning you whether to higher center or lower center, because the protocol you're following, I think that should be okay. People will question for anything. There's no, but as long as that protocol, I think medico-legally and ethically, you are perfectly okay, I think.
Sir. Yes, that came
So one
okay, sir,
point,
because that case went on, but the reference was to a VR surgeon for higher center where VR surgeon was available. That was the reason that the technical committee had ophthalmologists, sir, whoever came and inquired. Thank you, sir. Yes, Dr. Sudarshan.
There was one case of endophthalmitis which I referred to a higher center because we were not in a position to tackle it. And I ended up paying 2.5 lakhs for that patient. So just imagine if I wanted to refer all these cases of TASS to a higher center. So definitely it is not possible. So I would depend on a local VR surgeon who is available in the neighborhood. Thank you, sir.
That's a
So you're
perfect
saying
thing.
they are more cost economical, is it? We are surgeons?
No, sir, not. So, no, not
If,
only that. See,
if friendly,
probably,
we are surgeon.
no, sir,
Just
probably
joking,
I
sir.
would put it that if you initiate the treatment on a timely manner, you have given intravitreal injection or started topical antibiotics and steroid, and that is more important rather than without starting treatment, sending to higher center and then
Exactly,
treatment
sir.
get delayed. I think that create a more medical legal issues and a lot of hue and cry. But if but you initiate the treatment, I think there's no issue at all. I mean, if
Absolutely,
all of
sir.
us need to, what is more important here is I think every ophthalmologist should know how to give intravitreal antibiotics.
Injection.
And if they know, I think I don't think there should be issue.
Absolutely.
Supposing it's a case of cluster of TASS, how do we explain to the patient that this is happening? This is very important from the patient point of view, especially from small centers.
I think, see, I mean, what you rightly mentioned, you are not going to answer to the group of patients. You are going to talk to them one-to-one, and you tell him that, yes, you have this problem, and like we are handling, we are looking at it. There are various possible options are there, what you see, and we investigate and come back. But however, we are initiated treatment. It is like a not addressing for a group of 8 or 10 or 12 people. I think it's one-to-one. Probably, if you want to keep them admitted, keep in a separate room, not in a ward all together. Definitely not.
Just to add to Dr. Pramod's point, I think apart from having the mindset to treat in your place, you should also have the infrastructure facilities like B-scan. So if you have all these resources available and have a strong heart, definitely you can continue with the treatment at your place. It's not only cost effective, but also give confidence to the patient that everything is available within the center. And the main thing is keeping the communication on and documenting each and every step. So that is more important in medical legal aspect than really referring and at the jerk of the case, referring and following the case. So very often the follow-up is very important in these cases. And once you refer to a higher center, the follow-up might be difficult for small centers. So you have to have, like Sudarshan said, better to have a local support group and also support systems available.
Supposing a case is diagnosed as TASS with an expertise, sir, how long do we wait to see whether it recovers, or when do we intervene, sir? What is the advice, depending on the degree or response of TASS?
See, there is no magic number, but when you initiate treatment, probably as you see for a few cases, Dr. Sudarshan has spoken about. I think, see, and what your initial experience, your opening remarks, I think that's exactly right way of looking at it. Within first 6 to 12 hours, if an intense steroid, if patient is definitely responding, then you can afford to continue treatment and wait and give some more time. If they are not responding, or if things you feel they are further worsening, then obviously you have to take a call. And even you talk about TASS or sterile endophthalmitis or sterile inflammation, where you have a lot of endotoxin, definitely that scenario, washing antechamber or taking for vitrectomy, because you are just reducing the quantum of that endotoxin, probably will be beneficial in a long term. But yes, the moment you initiate, I think first 6 to 12 hours, probably typically in a TASS, you will see a response definitely. Dr. Kalpana can, I would say, add on this some more.
Madam?
Or anyone
Like
can
ma'am
just.
is away.
Anybody?
Can I add?
In my experience, it took 4 days for me to see the initial response. Only thing that I was relying on was good glow, which continued all through. And because good glow was there, I continued to treat. It was on the 4th day that it was not increasing any further. And I continued with the same line of treatment. So the 12-hour to 24-hour improvement may not be seen.
Yeah, probably if you are having a facility and you do a AC tap, and if that shows no organism either on smear or culture also, that another point you can have, you would like to continue treatment, then you have breathing time a little bit more than one. Rushing for. Yeah, please go ahead, sir. Sorry.
Yeah. In 2 of my cases, the first day they had very intense flare and cells. And we had asked the patient to use frequent steroids. And we called the patient next day. The flare and cells had reduced, but second day there was a small hyperpia, but which disappeared subsequently. Has anyone noticed such a kind of reaction?
Yes, sir, because it will happen, particularly patient is sitting and with a gravity, few things, those things settle down. The small stick you will see, and if you're lying down, probably you will miss it. But if patient is sitting, you will see that one, and thus it vanishes quite some time. It can.
Basically, sir, the reaction also varies from person to person depending on their immunity. For some, it is mild, for some, it is severe. So there it is difficult to differentiate, sir.
The only problem here is sometimes with the intense steroids we are giving, it may mask actually infective inflammation also. And then when you slowly like reduce steroids, and then they come back with a full-blown thing, probably sometime that you have to keep in mind.
Yes, sir. Thank you so much, sir. So now when we identify a cluster of TASS, here fortunately or unfortunately, there have been many reports, so we are able to pinpoint on particular consumable. Supposing it occurs in a hospital, there are other things than the consumables which the hospitals practice, which can lead to TASS themselves. So can I get somebody to talk about these possibilities where TASS can occur because of changes in the protocols of sterilization or anything? Dr. Shivkumar would like to take this question.
Yes, sir. I think usually the pinpointing of the offending agent is usually by exclusion, one by one, changing them one by one, changing your company or changing your batch. But before we jump to that, the first thing that we have to look at is our sterilization protocols and cleaning protocols of our instruments, whether there has been any change, what is the quality of water as was rightly pointed out, what is the quality of water, its bacteriological levels, endotoxin levels, and whether there has been any change in the person doing it or whether the procedure of that being done has anything been changed in that. So the first thing that we have to look at is our sterilization and cleaning process. And that happens to be the major offender as far as TASS is concerned, before we go on to blame any of the other products that we use in the chamber, or whether IOLs or whether viscoelastics or irrigating solutions. Yes, sometimes they have been implemented, but more often than not, the first thing to blame is ourselves. We have to look at our systems, we have to look at our processes, and we have to look at the way that the instruments are cleaned and whether they have been thoroughly cleaned or not. So I think that is the first thing to do. And then we can exclude these one by one. When you have more than 2 or 3 cases, as was done by Sudarshan sir, you have to, sort of weed out one by one what was the infected, what was the inciting agent, and change the batch or change the manufacturer, and then see if it stops. And then again, it takes time. It takes a little bit of time. But in the meantime, the first thing to do is to clean our own stables.
Yes, sir. Thank you, sir. Thank you. Actually, I suggest that we have a protocol on workup. Even sometimes when we get one case of infective endophthalmitis, we need to work it up, do a root cause. We have to find out what it is, because sometimes it's one or rare cases, 1 or 2 in a month or something can suddenly become a cluster also. Maybe we should develop one. The difference is very little. How do we go about investigating for a cluster of TASS?
In fact, if it is a TASS, there need not be a cluster. So I think even a single case should attract our attention, and that is what is the definition of epidemic case. What is not expected, if it is present somewhere, then it becomes an epidemic, and immediately it warrants suitable investigation. And investigation should generally take all the variables into consideration. And because of Sudarshan going ahead in the path, for many of us, it was easy, because immediately we could lay our finger on this particular RYCF lens. But otherwise, I think this is the pattern that we need to remember for life and keep recalling it whenever we find such a case. And at this point in time, it appears that only the differential diagnosis is with infective endophthalmitis and a toxic syndrome. So these are the two things that you need to keep in mind and approach whether to differentiate either of them and treat it further.
Yes, sir. Yes, sir. It is not. It is like a not a never again situation like infective
Certainly, we will face,
endophthalmitis.
and probably there will
That
be
is the
another
idea of this
webinar.
whole discussion.
There will be another webinar organized by you, I think, a few years down the line.
Yeah. Yes.
Thankfully,
Here we
few years
have.
later.
Yes, Dr. Nirmal. Yeah.
One thing,
So,
see, most of us, once we come across a single case, we treat and or refer and then forget about the case. I think we should develop a culture of reporting. And so one is reporting within our organization. So you have to incident report, find the root cause for every case and see where exactly is the fault, whether even after the case is recovered. And the second one is reporting across the country. So if there is a registry, you have to report. And if we find the culprit, what exactly is the agent, we have to report to the appropriate agencies like Pharmacovigilance Commission, and as well as to the consumables and supplying vendors. So this is where we are lacking. So the companies are not taking into task. We think we don't have the infrastructure to arrive at a conclusion. Even though we don't have the support system available now, it's our duty to report not only to the association but also to the company, give the batch report and ask them the report of that particular batch. This is very, very important for us to prove the case. So we have to get the supplier's batch report, the toxicology report, as well as the entire supply chain report from the company. So this is very important if you're going to deal with that mass or cluster later on.
Thank you, Dr. Nirmal. Coming back to the incident I told, that became a Pseudomonas cluster. And we found out unopened bottles of ringer lactate having the same Pseudomonas. So this was the case against the hospital was going on parallelly. We sent a notice to the company saying that your unopened ringer lactates have Pseudomonas. He gave only one answer: this is not meant for intraocular use. That's where the matter ended. So we couldn't do anything regarding that. So this is something I want to say. So when you have a single case of TASS, do we recall the other patients? Supposing it's a batch of 3 or 4, we do a recall when we see infective endoff, when you know the solution is involved. So when do we recall for TASS? Nirmal, yes, madam. Yes, madam.
I think it's better if you are very sure that it is a case of TASS, better to recall, because sometimes there is no pain, and some of these patients may not come with complaints of blurring of vision unless there is, redness and severe pain.
We have lost your audio.
I think
we can hear.
Better recall, yeah. But that's my opinion.
There is a case we have seen.
Recall is mandatory for every case, right? So the moment we come across a TASS or endoff or a case under investigation, so we have to go back and recall all the consumables from the stores as well as from the theater and from the end user as well. So this is where reporting helps. Right, so for that we need to have a tracking, right? Sudarshan did a retrospective thing. So what I'm suggesting is to have a prospective thing. So once you report, you have to go back, see the root cause analysis. So what could be the cause and try to arrive at the solution with. So that's where noting the batch number, noting the lot number, all those things will really help, including our own sterilization methodology.
This PVPI, Pharmacovigilance Program of India, is very vibrant, not only for ophthalmology, for all the fields. I have taken the certificate course for the orientation. There is an app and there is an online website also. Unless we report on this site and then it is proven that it is this group of companies, this group of whatever consumable, action cannot be taken. our associations like AOS or TNOA do wonderfully well in collecting data and telling the members that this is happening. But to go each person who's involved, each hospital involved, they must report on their own for PBPI to take it forward, because they are the actual users of these consumables. So we need to activate this, because it is also becoming very important for NABHS. Dr. Nirmal would be agreeing. It is very important, and this material vigilance program is for consumables. Right now, PVPI takes for IOLs also. Any more points on that, Dr. Nirmal?
I think you already said that. So we have to sensitize our members to report to the right authority. So from QCI, Quality Council of India also, we've reported this. So hopefully we waiting for the report and from the company as well as from the Pharmacovigilance Commission.
Yes, Dr.
Once we
Sirish,
get that, we'll share the inputs.
See, there is an additional point that we are all responding to cases which have crossed a particular threshold, and before we label them as TASS. Whereas there must have been a sub-threshold inflammations seen by either of these surgeons or most of them. Like, for example, if we have seen, say, 100 cases, there must have been another set of 100 cases which must have had half the quantum of inflammation and must have missed being labeled as TASS because of the respective person's immunity and all that.
yes, sir. Compared to 15 years or 10 years back, now the reporting is much better, whether it is TASS or infective. More reporting comes, we are learning from that. It is absolutely true that unless we report, because there is a fear, it's a panic situation. Just to tell it out only, just to recall, people will say, why you want to blow it yourself? Let them come if they have a problem. But on the other hand, an ounce of prevention is better than a cure. So we need to go like that. So that is exactly coming to the same point. What are the medical legal implications? We have Dr. Nirmal, who is also a medical legal expert, on TASS cases or cluster of TASS. Even if the patient gets 6 back, that particular 2-week period, he would have been treated. What are the chances of him going against the hospital? And how can the hospital defend themselves, hospital or the surgeon? Nirmal?
Okay, see, many of these patients, if they are already told about the possibility of infection and inflammation, so we are in the strong position. So we need to have the consent formalities in the right direction. So recording this might help. The second aspect is the communication. So 90% of the errors happen in the communication aspect. So conveying the bad news. So this is a bad news. We have to convey to the right person, with not only to the patient, but also the right person in the patient family. So very often it happens that every day there will be one attender with the patients. So they may not be in the full know of things. So we have to document this also. Third is updating properly. So we have to update them as and when we see, as well as regularly one of our staff should be in contact with them as well as the family. The fourth is, I think somebody asked about the referral. So referral at the right time is more important, right? So not after the eye is lost. So when we are treating it and finding that there is a response and we are able to or confident about handling the case, we can retain the patients. So, but if you are not confident, less on the side of resources, then better to refer at the right time. And again, documenting the investigation. Whatever investigation we do, we have to be part of the medical record. We also have to retain a copy of this so the moment something happens, that red light should happen and we have to safeguard ourselves. So one, isolate the patient from the other patient also. So see them in a different room. So ensure that the communication is right. Try to record the communication, and after every interaction, get the signature of the patient as well as attender. So these are small tips that can help. Maybe others can add.
At this point, I'd like to mention more than 50% of the cases, medical legal cases against the hospital or doctors, are lost because of improper or incomplete consent forms. So this is something where we have to really work out and answer all the needs of an informed consent form. Yes, anybody else to take a call on this, please? Yes, Dr. Ramesh?
I think the most important thing is we have to tell the patient something is going wrong and we are doing our best for the patient, and the trust level has to be built up. These patients will generally disturb you and eat your brain and you're very busy, but we had to slow down the OP and we had to concentrate on spending time and effort dealing with the patient and the relations. The more time we spend before it becomes a medical legal problem, the safer it is for us. So if you're a surgeon, 1 in 5,000 or 10,000, you will have problems. Just put the brake. Don't worry about the remaining patients. You can cancel those appointments, but you have to be willing to spend time and effort. I generally tell the patients when I have a problem that you probably have a TASS. I had a TASS recently, but not due to the intraocular lens. And the patient's relation wanted to know what it was. So I told, this is what it looks like. You are going to become better. It's called TASS. You please read about it. This is what we're going to do. We're going to treat you. And like you said, see you frequently till you get better. And another thing I say is generally in cataract surgery, you see well the next day. Unfortunately, in your eye, you're going to be like those olden day surgeries. You will see well in a week or two or in a month or so. You won't see immediately, but ultimately you will do well. I will take care of you. So reassure the patient and make sure you have a very good bonding with them and spend time with them.
I think the trick in the socially managing these patients usually lies in spending more time with them, but not giving them too much of undue attention that they start smelling something is wrong. So I think it's a balance really, because when you give undue attention, also these patients start suspecting you. You cannot antagonize him. You have to treat him nicely. Yes, all these things, but at the same time, treat him normally. Don't get irritated with him. Treat him normally. Don't give him too much undue attention. Then they start smelling something is wrong.
I agree with you totally. Very, very important point.
Yes, Dr. Shivkumar, sir.
You're muted, sir.
Answer, just to complete it, it's for TASS and maybe even for the sterilization to prevent endophthalmitis. But the American ASCRS task force for TASS has recommended, has given recommendations for cleaning of instruments and prevention of TASS. And the main thing that is written is that you should have followed or you should follow the DFU or the directions for use for both the cleaning as well as the sterilization of the instruments. Now, therefore, apart from all this, what is needed is to have really well written protocols following the directions for use, single use, reuse, or whatever, and sticking to those protocols so that when it comes to a medical legal case, we are on the safe side. So I think that is something the fine print is all missed. And this is also taken advantage of by the manufacturers, and they have to face the music in the court. So the directions for use is to be followed. It has to be in the protocols. The protocols have to be according to that, and the protocols have to be followed according to that. So whatever the amount of fluid, whatever detergent, whether it should be used or not, whether enzymes have to be used or not, everything should be according to manufacturer's instructions, and then you are safe.
True, sir. That is why some of the people are being extra cautious. They re-autoclave, they re-sterilize some of the IOLs. Previously, when ringer lactate came in bottles, we used to do that. Those things and all will go against us from the manufacturer's point of view. Yes, Nirmal?
No, I think Shivkumar has rightly put this. The manufacturer's recommended for usage. So it's not only with reference to reusable, but also single usable devices. So plus the consumables, sharing of consumables. So now most of the insurance companies also requesting what are the reused consumables as well as single-use consumables. They are also wanting a declaration that we have told the patient about the reusable nature. So it's really becoming very complicated medico-legally as well as from the insurance aspect. So the right thing is to follow the manufacturer recommendation. And of course, before that, we need to have a hospital policy on what is what should be reused, what should be sterilized, what should be re-sterilized. So we need to have a policy on this first. And very often we see things are being re-sterilized. So sterile equipments being re-sterilized like BSS, viscoelastics, and the other intraocular components we use. So these are going to actually increase the incidence of TASS, because we are with chemical or heat sterilization, we are altering the pH, we are altering the constituent of the material we use, and we are also altering the surface of the lens if we are going to re-sterilize it. So we have to have this in consideration before devising a reuse policy and re-sterilization policy.
At this point in time, I would like to say there are authorized laboratories where we can do the work. For example, the same batch IOLs or the same batch consumables of liquids or whatever, they should be tested there in order for us to raise a query against the manufacturer. So here I would like to, because our lab has worked up on some lenses, because clusters have occurred and they have sent the lenses to our lab. Mr. Krishna Kumar from our lab can tell us what investigations they will do for a lens sent for workup and what are the endotoxin levels that are acceptable. Over to you, Mr. Krishna Kumar.
Thank you, sir. I'm hearing as you all talk. So first to answer your question, whether
your voice is breaking. Your
voice is breaking. Voice is not clear.
Voice is breaking.
Is it better, sir, or it is still lower?
It is better.
Now it's better. Yeah.
Okay. So
if
when
you
we
switch off your
lenses,
video, it might help.
Yeah, you can switch off your video and talk.
Okay. Okay. Is it better, sir, now?
Much better.
Yes.
Yeah. So what we do when we receive the lenses, it is most of the time suspect the endotoxin of the endotoxin limits of the lenses. So as per the given norms, which is an international norm, ISO 11979, is the standard recommending the endotoxin levels for IOLs. It states 0.2 EU. 0.2 EU is the acceptable limit. In US, it is 2 EU. 2 endotoxin unit is all okay. But when we do these tests, there are possibility because these endotoxin tests are done by different methods. The normal method is gel clot method. That is what people currently using in India to make sure whether the endotoxin limits are within the prescribed norms. So it has its own sensitivity and other things. So even in our lab, we use only gel clot method. So, but the cautious step what we have taken is we have not stick to the limit prescribed by the international standard. We have lowered it because we are doing internally when the lenses are going outside, when it is being tested in outside lab. There are various reasons for the test can fail. So we have to limit the endotoxin way below the prescribed norm. Then only we can be very sure all our lenses are okay when it is reaching the patient's eye. So this is the step we are following. But when we receive other company lenses, we test to the prescribed norms of 2 endotoxin units. If it passes, then we cannot say it is all okay, because what we receive is just a sample. This endotoxin, in a way, it is a process validation parameter. I'd like to touch upon this aspect because this endotoxin comes from the bacteria. So if the bacterial load is more during the process, we cannot say one lens is having 10 bacteria, the other lens is having 100 bacteria, because we cannot predict where the bacterial load. Even I make 100 lenses in a lot, even though it goes through the full process without much deviation, there are chances few of the lenses to have more bacteria than other lenses. So it is a sampling process. That's why the companies are asked to do a process validation. So we do a lot of steps to ensure even if I take sample, I can guarantee that the entire batch is up with lesser validation. So this is from internal perspective, sir. When we receive lenses and test it, we can only say pass or fail, but that is not the assurance that all the other lenses which are there in the market is okay. So the only option is to check with the manufacturer and ask the manufacturer to cooperate and ensure whether they are having the right process. Is there any changes in the process? Could be a reason. This is how it has to be handled, sir. And the other aspect we have been talking about, this PVPI. So it is also a great platform because things are happening at different places at different times. That's why the government has come up with PVPA. So if all the people who are affected, it has been loaded, it gives the weightage for the DCGI to look into it. Then it can raise the issue in a much better way. And Dr. Siri sir was asking about what was because we are talking about all the happened cases. There are some sub-level cases. We call it as near incident or near miss cases. The process is the hospital has to have a trend analysis because they know for one task to happen, there could be some incidents before that. If it is a hospital bound issue, if they have a record, if they have a track and trace mechanism of all the batches they are using, then they could figure out the near miss cases also as a trend. For the manufacturer, it is there. We have our own trending, though there are complaints. If we have any internal elevations in the endotoxin or in the monomer or in something, we used to have a trend chart that if it is going upward, then something is there in our process. That's how the hospital also have to record and trend so that they will be able to, is it happening only in the winter month or is it happening in particular OTs? So those things will help people to figure out before it happens. And a few doctors have been talking about water. They have been using Bisleri. There is nothing as a sterile water. Bisleri is a drinking water norm. So the given norm is 500. There can be a bacterial limit of 20 bacteria can be there in a ml. ml of water will have 20 bacteria. So then if you use 500 ml or 1 liter of water, there will be a chance of more amount of bacteria, but that is not going to cause any TASS. So what the precaution we have to take is when it goes for sterilization. In the sterilization process only, the endotoxin thing is emerging. Prior to that, it is all only bacteria. When it is being killed by the endotoxin, it releases, it will become an endotoxic material. So what we recommend is, if you have a tight control on the water being used with less amount of bacteria, then your own internal sterilization process may not release endotoxin. The other thing is, for washing and everything, we have been using some quality water. At the end, if it is used, if it is rinsed at least by a better quality water, which is having lower bacterial load, that will also help the hospital to get rid of hospital sterilized items releasing endotoxin. These are the various things I have been observing, sir. So I'm not sure whether I've answered all your queries, but this is what I have.
Thank you, Krishna Kumar. Thank you. I think also we need over 140 degrees to kill these endotoxins. No? Normal
Yes,
autoclave will have only 120 degrees.
Yeah.
These endotoxin will survive in 120 degrees, isn't
Yes,
it?
160 degrees, sir. 160.
160.
Yeah.
Thank you for your
Is there-
inputs, Mr. Krishna Kumar.
Yes,
Yes, Sirish, sir.
I would like to ask one specific question to Mr. Krishna Kumar.
Yes, sir.
Thank you, Mr. Krishna Kumar, for enlightening this processes so well.
Okay.
Is there some solution in which, if we dip the IOL,
Yeah.
and all monomers will be washed away, and after that it is perfect to use?
Sir, monomers will not go away, sir. Monomers will not go away, but endotoxin will go away, sir.
All right.
If you rinse it in balanced salt solution,
That is sufficient.
but the issue is, if it is a hydrophilic lens, we have to wash it thoroughly, because the water, which also has endotoxin, is squeezed inside the hydrogel lens, hydrophilic lens. So if you wash it thoroughly, so that until it is going into the monomers and things like that, then the endotoxin can go away, but not the monomer. Monomer will not get rid.
But what is the method of removing the monomers normally, even industrially, for example?
Sir, actually, we use multiple monomers to make a polymer. The lens is a polymer. So what we do is we do lot of extraction process. Sir. It is not removed at the end of the process. The making process itself should ensure there is very low monomer. It should be less than 1% monomer in a lens. If it is 100%, the allowed limit is less than 1%. So how do we test this? We put that lens in a solvent, whether it is water or in a other chemical solvent. We reflex it for 48 hours. We boil it for 48 hours and take the water out. Then we do HPLC analysis. From there, we get to know what is the amount of monomer there in it. This is how we decide this batch of raw material is having less than 1% prescribed monomer. But as you asked, it is not by cleaning or by doing something at the end of the lens making, it is not happening. The process should be rigid so that all the time it produces a lens or a material with less than the prescribed amount of monomer. That's how it is being done.
You are merely testing your process rather than modifying it.
Yeah,
modifying the monomers.
Yeah, that's why it is called process development and process validation. Before we release the first lot of product into the market, when we develop the product, there will be a lot of tests. One is this process development and another one is process validation. If we are 100% sure after 5 or 10 continuous concurrent validation, then only that is a process for making the material for lenses. That's how it is being developed.
Wonderful. Thank you so much,
Wonderful.
Krishna Kumar.
Yeah.
Thank you for. Sir, we have another 10 minutes, Dr. R.K. sir. Shall we ask one final comment from each of the panelists and experts here?
You can extend the.
Yes, sir.
If you want,
Extend
you can.
also. Yes, sir. Yes, sir.
Exactly,
So I have one question for Nirmal and Krishna Kumar. What is the liability on the manufacturer? See, for example, this particular lens manufacturer said, our processes have shown to be normal, okay, but temporarily we advise not using this particular group of lenses. So still now we do not know what is the status. So how we can face, supposing there is a problem, there is a claim by the patient, what is the role of the manufacturer when the problem is with the manufacturer?
Sir, we also have an insurance coverage, sir. So every company is supposed to have a product liability insurance. So we also hold insurance. When things go wrong, we will use the insurance to cover the patient's claim.
Patient's claim.
Yeah.
Yeah, definitely, whatever it is.
Yeah.
So it will not be on the hospital at all.
Yeah, the patient is affected, sir. That's what.
Yeah. Here the ultimate consumer is only the patient, no?
Yeah.
The liability will be with the product producer, manufacturer, but it will come through the hospital.
Yes.
Because no patient is going to go against the manufacturer.
Yeah. Yes, sir.
Yeah, but how many times, just to add on, how many times patient go against the manufacturer? Because most of the time he just blame hospital.
Yes.
And what your opening remark, again, what you mentioned, that most of the time manufacturers, they just deny that our process is perfect, or what you rightly mentioned, it is just single use, or you said this is not meant for ophthalmic use. So they wash their hands off. If they accept the claim and that responsibility, then only that insurance part will come. Their own. Till that time,
this is where the PBPI and the DGCA actions will help us, sir.
Yeah,
Directly we cannot take it, sir. This is where the PBPI reporting and DGCA will go a long way.
No,
yes,
there are two issues here, Chandru. So one is the court has to find us negligent. And second thing is we have to prove that negligence on the part of the company. So these are two aspects. Right, so company is having a vicarious liability. They have given one product which you have used, right? So it's our duty to prove that this product was wrong, that are defective, and so the blame has to be shared. So the court itself will share the cost, right? So the cost to the company, cost to the hospital. So this is how it is usually. So it's very rare in our country to take the manufacturer for TASS because so many escape routes are there. Even in this incident, so the company people were giving so many recordings. I have to warn our people, right, on their interaction with the staff, hospital staff, on how they are sterilizing, how they are re-sterilizing, how they are using the product. So they were showing recordings that how our staff are not washing properly. So, okay, the casual remarks are all being recorded by the company representative, right? Re-sterilization of BSS, autoclaving the BSS, and sharing the viscoelastics, and then sterilizing, autoclaving viscoelastics. All these are incidents which are captured from the mouths of our own staff. Okay, so company has a lot of escape routes here, and it is our duty to sensitize our people, train our people also in this regard.
So those remarks should not be there in front of this company people.
Yes.
Let it be just totally internal.
No, our people are so friendly with them, right? Because they are interacting with them on a
That's
daily
exactly what
basis,
happened.
so it's easy for them.
Yeah, I agree. We never realize they are recording something like this. Casual discussion goes on.
Yes.
True, sir. So this is an overview of some of the important aspects that come into the minds of a single surgeon or a hospital or an institute, which we have tried to address. And overall, it is a situation which is important. But knowing TASS is going on, it is easier to diagnose. But when you see fresh, we need to take a call, keeping in mind there is always an infective end off in mind. So I'd like each of the experts here to give one last point. So we'll start off. Yes, Dr. Sudarshan. You're muted. You're muted. You are muted.
One last question. With respect to the use of Bisleri or other brand RO, what I was doing was run the autoclave dry without any equipment inside for the first round.
Okay.
And in the second round only, I used to load the equipments into the autoclave. And by doing this, is there any additional protection? Or am I going to reduce the endotoxin level here?
No, I don't think so. No, I don't think so.
Okay.
See, about water, let me add 1 or 2 points. See, when we talk about RO water, that is reverse osmosis filtered water, we normally refer to that bottled water or alternatively commercially available water in cans or bubbles or plastic cans. See, that water is just made for drinking purposes. So therefore, initially it is filtered completely, which is, I think, pure water. And later, some raw water is added so as to make it mildly mineral rich. Or it's not rich actually. A few minerals are added by just adding a small quantity of raw water. So it is not sterile as such, but very clean. But it is at the same time not pure water. Whereas if you have an RO plant within your premises and you take that output, then that is pure water. Now, additionally, you could have distilled water also. And in order to prevent scaling, I use RO water in the distilled water plant so that there is no scaling there, or the scaling is reduced to minimum. And it is that distilled water which I use in autoclave. But this may not be practical in large hospitals. But my autoclaves, I just have 3 small autoclaves, small in the sense that 29 or 23 liter autoclaves. So I just run them, and this is very easy for me. But running a dry cycle at current electricity prices, I think Sudarshan is very brave.
But
Thank you.
Ideally,
Thank you.
if you're running multiple cycles in a day, your first cycle should be dry with your Bovidic, ideally.
Yeah.
Okay.
No, the purpose of that is to ensure your system working smoothly,
Yeah.
ideally. But that
Ideally.
does not give you added advantage
Protection.
that second load when it goes, it will more sterile or something. No, it doesn't prevent that way. That's what.
And I have a question to what Dr. Sirish said. Dr. Sirish, you said you're using distilled water for your autoclave. Without ions, the autoclave process itself is more difficult. Haven't you faced that situation?
Is it so? I have not even given it.
Even autoclave companies, they don't really advise us to use water without
they may
any
not
ions
advise.
at all.
No, they may not advise. The point is, the one tabletop Class B autoclaves have complicated tubing mechanism, the tubings inside, and I don't want any of it to be clogged or filled with scales. So therefore, I've started using distilled water. And ions have no role in producing steam, because there is another cycle of producing steam inside the autoclave, and there are no ions involved in it.
No, that's. But correct me if I'm wrong. I think distilled water itself is a corrosive.
So that may be corrosive, but the tubings are, Dr. Pramod, are all plastic.
The typical
Can you give
Class
some?
Bs don't do
Yes,
well
sir.
with
Yes,
distilled
sir.
water. That's what I
Sir,
learned.
there are a few things for scaling to happen. The water should have a hardness. The hardness is normally being removed in all the distilled water. So distilled water is good enough to go ahead with any autoclave or something. And ion is not having, that means these ions are not having any role to play with respect to sterilization. Why this multi-column distilled water is not normally recommended for autoclaving is it is so pure, so it is highly corrosive. It is reactive in nature, so that's why people are not recommending that water for autoclave. This autoclave, when the heat is going to 121 degrees C, that's what we have to ensure whether your autoclave at multiple locations is achieving 121 degrees Celsius for the entire duration of 15 minutes or 21 minutes. That is what critical. So the Bovidic test, what it ensures is it has to achieve all the required conditions. Vacuum. Actually, before the sterilization starts, the air inside the autoclave is being completely vacuumized, or it is being reduced, so that the steam can penetrate in all the area. If there is a air trapped in the autoclave, then the steam mixing may not be very thorough. That's where some of your instruments may sterile and some portion of because as you all talking about tubing and other things, the inner lumen of the tubing has to be attained with the steam and the required temperature. That is what ensured by Bovidic test. If you do the Bovidic test, then you do with this RO water, that is good enough to get rid of this scaling or any other issues, and that is okay to go with this autoclaving process.
So class 6 indicator in each of the surgical set will do the best, and the PCBs will tell the process has been good, isn't it, Krishna Kumar?
Yes, sir. If that is being done, it is good. If they have this class 6 indicator and if they can use, that is good. But I am not sure whether it is being used.
Yeah. No, normally they use a class 5 or class 6 per bin in some institutions and per set in some institutions. That also depends on the numbers.
Yeah.
But using one per bin doesn't ensure the whole bin or the whole set is sterile, isn't it?
It is not so, sir, because your sterilizer has to be validated first. For example, you have a new sterilizer every year, or if you have a old sterilizer, every year the sterilizer has to be validated by putting multiple biological indicators or class 6 indicators. For example, you put per cubic meter volume, you have to put 12 biological indicator, and 3 cycle you have to validate. And if all the 36 indicators shows no growth, then the sterilizer is okay. But we cannot repeat for every batch. So it is a monitoring mechanism. We have to go with the less number of biological indicator. To put the biological indicator, they ask us to identify the coldest part of the entire this bin. So we have to find that, and those locations we have to keep 1 or 2 indicators as a monitoring parameter. If the sterilizer is validated, then it is good enough. If it is not validated, means it is not the right way, sir.
Which will be the coldest part of the bin?
The near to the drain point, sir. See, when the process is over, the near to the drain point, usually that will be the coldest point. But this we will do, we will identify by means of validation. There are third-party validating agencies. When they come, they put thermocouples inside the chamber. They'll put 12 or 15, and they will monitor every place. They will record. Then they will say this is the coldest point of the sterilizer.
Thank you, Krishna Kumar.
Yes,
so we'll start off with Dr. Arul sir for his final comments, sir.
Yeah, the point that I want to make is that if you have a tailor-made RO unit for your hospital, you can have a tailor-made one where it does not mix back unfiltered water to bring up the TDS count to drinkable levels. That itself will give you a water that's pure enough for doing autoclaving. I do have a distilled water unit, and I take out distilled water and use it. Most important in all the autoclaves, it should, after the end of the autoclaving process is over for the day, the tank should be meticulously cleaned and dried totally, because you don't want any biofilm to form. So these are the points that we need to keep in mind. And of course, we should always think about not using any detergents or enzymes for cleaning any instruments. If you do so, you have to wash it thoroughly with clean water, preferably distilled water, and then dry it completely before blow drying it again. It should be dried. You should use a hair dryer, simple hair dryer, to completely dry out all the instruments, and then use a filtered air gun to blow dry all the instruments and all the hollow instruments that you reuse. Reuse as less hollow instruments as possible. Throw away all the cannula on single use and use disposable cannula. Probably the only hollow instrument you will end up using would be the IA tip and the phaco handpieces. Blow dry them cleanly and thoroughly. The other thing we tend to reuse are reusable cassettes. Be very careful in cleaning them. Preferably use disposable cassettes, and preferably you have a load that is commensurate with the expense involved. If you put all of these things together, our chances of TASS will come down. But the other thing which cannot be monitored is the multiple number of intraocular material that we put into the eye. We start with intraocular anesthetics, we ask intraocular mydriatics, and we have viscoelastics, and we have antibiotics. So any one of these can cause TASS, and that is something that we need to look at. Every single product that is used, the batch should be recorded against a particular patient. So if there is a trace back, you can go back and trace out that batch and try to figure out if there were other incidences or subclinical incidences on the same batch, and try to figure out what happened. So this is an exercise that we should all do. First is a recording. It's extremely important. Every single product, the batch should be recorded against every single patient in your logbook in the OT. That's the only way that you can go back and trace it.
Thank you, sir. Madam, your final comments?
Actually, I was going to re-emphasize on the same thing, the documentation, and also, the use of intracameral. Only if it is indicated use, because I've seen even if the pupil is dilated, as a routine, they use Phenocaine Plus inside the eye. So try to minimize the usage of intracameral agents as much as you can, and a proper washing of the intraocular lens. Sometimes they say that, a good washing of the intraocular lens can sometimes make a difference. The endotoxins can be washed away. So that is one point. And again, documentation is very important so that you can always look back and see, what went wrong. I think that's what would be a final message.
Thank you. Thank you so much, madam. Dr. Pramod sir, your final take.
Yeah, there are a couple of things I would like to say here. Like tubings, we already discussed, but the joints of the tubing, quite sometimes, those are the niduses, or dead tissues, or some rusting, some just accumulate there. So those are things you need to focus when you are cleaning the tubings. That's an extremely important thing. And again, Yes, documentation is important. Actually, I wanted to emphasize that each institute should have their own protocol, but post-surgery, probably whatever consumables we have used, we do not discard those immediately. I would say just tie those up, keep for at least 24 hours, see your patient next day. So at least leftover consumables, what you have. Suppose you need to, you can use Sendos for culture or something, at least we have those material. Otherwise, immediately you discard. And then if that is a standalone thing, again, everybody denies, then you don't have sample left with you to analysis.
Thank you, sir. Thank you. Dr. Ramesh?
I think mostly it has been covered, but personally, I feel that when my problems have happened because the OVD has not been cleaned properly and they've been coating the instruments or the cannula. I think cannula is very important. We should replace it more frequently if you can afford for each case, otherwise at least every week. So washing is very important, and also the tubings. So in the tubings, the couplers are what is difficult to clean and they change color. So in my hospital, we have extra spare couplers in bulk. So we reuse the tubings and we autoclave one set of tubing for each patient, and we change the couplers once in 2 weeks or once in a month. So the tubing is the old one, but we're just changing the tips. That's it.
Thank you, Ramesh. Thank you. Dr. Sirish, sir?
Because many of my colleagues have spoken about reusable tubings and as well as reusable, the cannulated instruments. See, all these instruments, we only aspirate and we don't push anything inside. I'm purely from logic and pragmatism. Even the reusable cassettes, the residues could be only in the aspiration line far behind you, not near the eye. So therefore, if you only aspirate and not say reflux or push it forward, then nothing should normally happen. So I have never faced it, but that doesn't mean that does not exist. But my logic says that if you rely on good, reliable autoclaving, and I rely on except heat, nothing else. Even sharp instruments, I take them as consumables. I use them only say 5 cycles and it becomes blunt and I throw it away, but only heat. And I use just 2 chemicals inside the operation theater, which is one for fumigation, the other for swabbing and wiping. This apart, there are no chemicals at all. And everything is only distilled water and nothing else.
What do you use for fumigation, sir?
Fumigation, the quaternary ammonium compound. Say what is sold for about say 2 liters to 2,000 rupees or 1 liter 2,000 rupees, something like that. So that alone. So the name is very difficult to remember nor pronounce. It's very, very long.
It's a long
that
name.
apart, what I use is only benzalkonium chloride in whichever commercial form it is available. So this apart, there is nothing else that is used in my OT. But then my OT cannot be the standard or to be emulated. So mine is a fairly a smaller, that is smaller turnover OT. But then if this is done, perhaps I think we would not be surprised far too often.
Thank you, sir. Thank you, sir. Dr. Shukma, sir? Short final comments?
Sir, I think everything has been wonderfully covered, and I will just would like to probably it can never be overstressed. The first thing that has to be done soon after use is to never let the instrument dry with the biological load on it. Is to wipe it or to immerse it in water so that it doesn't dry and cleaning becomes easier and more thorough. So I think that's the only thing I would like to stress. All other points have been covered.
Immediate cleaning and tubing to be cleaned immediately.
Immediately reduce the bioload. Don't let it dry on the instruments because that makes cleaning more difficult and less thorough.
Thank you, sir. Thank you, sir. Dr. Sriram?
Yeah, I think most of the things have been covered so far. Just to avoid repetition, I would probably go into what you do after you find TASS. So always do a thorough clinical exam and don't forget your B scan. Those are the only 2 points I would want to say.
Thank you, Sriram. Dr. Sudarshan, sir? You're muted, sir. You're muted.
Yeah, with respect to what Dr. Sriram said, almost all my cases, the first thing I used to see was look at the anterior vitreous. Is it clean? Are there any cells? There are no cells. That means you are sure that you are dealing with a case which maybe you can take care of it yourself. So thank you, sir.
Thank you, Dr. Sudarshan. We have two young surgeons,
Dr.
Atik
Pramod,
and
I think
Dr. Yes, sir. Yes, sir.
Dr. Pramod
Yes,
is
sir.
raised his hand.
Just one thing
Yes,
I
sir.
wanted to add here, because most of us enter in theater by the time patient is already draped. Okay. So, and so trolley, everything is tray is open. I think make a practice when you open the tray, check the tray. It has to be dry. If there's a condensation there, consider it unsterile. Don't use that one.
And all the instruments associated with it autoclaved in the same cycle.
Yeah, it has to be,
That
it has
is
to be
true,
dry
sir.
totally. It won't dry. It has
Yeah.
to be inside condensation. That means it's not sterilized. Just
Yeah, because the vacuum cycle has not been good, or the drying
Absolutely.
cycle is not.
Yeah.
Thank you, sir. So two young surgeons are there, Atik and Prasanna Venkatesh. Atik, you would like to tell anything about this situation?
Atik is a little indisposed now, so he won't be able to talk. He's driving actually.
Oh, sorry.
We'll move to
Prasanna?
Prasanna.
Yes, Prasanna.
Thank you, sir. I think I learned a lot from this session, especially starting from your take on cluster endophthalmitis, cluster TASS and cluster endophthalmitis. So all these are quite new, and I've learned a lot from this session as to even examining the anterior vitreous phase and how there is a cells or no cells are present, how we go about managing that case from differentiating a cluster TASS from end of. Yeah, that's what I would want to highlight. Is.
Thank you, Prasanna. And now we'll move on to Nirmal,
yes, sir,
who is an ophthalmologist, a medical legal expert, quality expert, and whatnot. Nirmal?
Yeah, thank
And
you.
he's
Sir.
also Nirmal.
Only Nirmal. Thank you. I think all of them have covered everything. So nothing to add much. A few things. Very often, if we go for this TASS or end of investigation, most often there's one linkage that there is a intraoperative complications and usage of emergency drugs, emergency instruments, and not so often used instruments. So we need to have a proper inventory and backup. So every theater should have an inventory and backup for any complication we expect as well as not expect. The second point is the over usage of chemical sterilization. We have to limit chemical sterilization, maybe ETO after good aeration, but all other method of chemical sterilization should be stopped or reduced. And so this is very, very important. Very often we see during assessment that instruments or the phaco tubings are either surface cleaned with chemicals or the instruments are washed with the chemicals or put in the chemicals. So this is one thing that has to be not followed everywhere. And the third aspect is we already known report and analyze each and every case. So if there is an incident in a small setup, take a break of say 2 or 3 days, analyze, find the cause, and then see what could go wrong or what could have end up in a cluster. So avoid those things, take a break and then restart after a proper incident reporting and analysis. And of course, escalate to your association so that we can also help you.
Yeah. No, there's two things to add to what Dr. Nirmal said. One is regarding this chemical sterilization. I think we should make it explicitly clear that formalin chamber is a big no, because it is still practiced in a lot of places. It's a big no and it is still practiced. And the last point which he mentioned, escalated to the association. I'm sorry to say that Sudarshan, yes, he did a wonderful job by reporting those cases and came up with an analysis so pakka. But we sent out the information to the other TNOA members asking for information, and unfortunately nobody else responded. The only thing calls I got was what was the problem and which product the problem wasn't, but nobody, I'm sure a lot of other people would have had, but nobody came forward. But well, by the time 24 hours had passed and the cat was out of the bag. So if you have a problem, it is going to be kept confidential. So please come out and share it with your association, because If you are not there for that, then what else are you there for? Thank you.
Thank you,
Association
Sriram.
usually means association executive.
Okay.
So
Okay.
here I would like to take a point. Most often, whether it's cluster or anything, there is always a problem involved with some other process. There are so many people involved starting from the beginning of, putting the drops to sending the patient out. So the surgeon does a good job. At the end of the day, it's on the surgeon. So here it is very important that you do a good job, make sure the others do it. Periodically, you have to make sure and, you have to train them, you have to supervise them, make sure they're even our sister touches in the microscope. For them, it is nothing. For us, it is everything. So it is important that we monitor everybody in the process. And as important as doing it properly, it is as very important to document everything properly. You cannot do it. For example, one particular incident, the consumables of 2 years were taken for that particular cluster. Consumable, just to see whether it was shared or whether it was used for many people. There are so many lessons learned from that particular investigation. So finally, I'd like to hand over to our Honorable President, Dr. R.K. sir, thanking him for this wonderful opportunity. Sir, over to you, sir.
Thank you, Chandrasekhar, and thank all the specialists for the wonderful discussion we had from A to Z, and TASS, not only TASS, and a little bit about the endophthalmitis and some of the sterilization techniques. Definitely, I think it will be useful for all of us, and also such exercise is very periodical exercise, very important to make ourselves aware of all these problems. Thank you once again, Chandrasekhar. And one more announcement. This month, guest lecture we have next the 20th, coming 20th, by a very famous orbital surgeon from Kerala Eye Institute, Christian Nelson. He will be giving a talk on 20th. I request all of you to join for that. And now I request our Secretary TNOA, Sriram Gopal, to propose vote of thanks.
Thank you, sir.
And also, I have to thank Krishna Kumar. I just informed him in the last minute only by 6 o'clock. I informed him. Thank you, Krishna Kumar, for the wonderful.
It's a pleasure and honor, sir. Thank you. Thank you very much, sir.
Outside, I'd start off by thanking our beloved President, Dr. Ramakrishnan, for thinking of this webinar and conceiving it. A big thanks to our ever eloquent Dr. Chandrasekhar, or DC as I call him, who seamlessly coordinated this webinar. Anybody who saw the invite would have wondered, how can you have a dozen panelists and have it's going to be a cacophony? But the way you had structured the webinar, the questions you had put out, and the way you seamlessly shifted from each expert, depending on their expertise and depending on the question, it was wonderful. And thank you so much, sir. I thought you're only a good quiz master, but now I realize you're a good ring master as well. Thank you. A big thanks to all the panelists, starting from our President-elect, Dr. Nirmal Frederick, our Vice President, Dr. Arulmozhi Varman sir, Adia, Madam Dr. Kalpana Narendran, my Guru, Dr. Pramod Bende, Dr. Ramesh Rajan, Dr. Sudarshan, Dr. Sirish Kumar, and Dr. Shivakumar. A big thanks to both Aurolab for the sponsorship for this session, and also to Dr. Krishna Kumar on a last minute notice. He was able to come and share very useful inputs. And last but not the least, thanks to Sai and Manjula from Numerotech for making this program possible. And I am supremely confident that this is going to hit the top of our charts in our YouTube channel, because it is not only people who watch it now, people take time off later and they are able to go back to the TNOA website and watch it on our YouTube channel. And so in that, we come to know which webinars are most watched. So I think this is very soon going to top the charts there. Thank you, everyone. Have a good night. Happy Pongal to you. And RK sir, one thing which you forgot, which I will add, we have the midterm TNOA coming up end of this month in Kutralam. So
Ramesh is already in Kutralam. Ramesh is already in Kutralam.
Yeah.
Wherever Dr. Ramesh is, it is Kutralam, sir.
Yeah. So thank you very much for allowing us to be part of it. It's a wonderful
So happy Pongal all.
And happy Pongal to everybody. Good night.
Thank you. Yeah, good night.
We can close the stream.